Dear colleagues, dear friends, good evening. My name is Vasilios Papanois. I'm a professor of surgery at Imperial College and the director of communications and informatics of the Association of Surgeons of Great Britain and Ireland. A very warm welcome to our session tonight. As you know, these sessions replace most of the work that we would like to do in a live Congress, but unfortunately couldn't do it because of the pandemic. They have been proven to be very successful, and I believe that tonight's session will be no exception, with the opportunity for a short educational session, as well as the presentation and discussion of some very interesting work in the context of short papers or posters. And I would like to pass it on to my co-host, Ms. Irene Bellini, who is a consultant transplant surgeon in Belfast. Irene, can you hear us? Small technical hiccup. I don't think that...
Good evening, everyone. Many thanks for the nice introduction. Without any further delay, yes, hello? Can you hear me?
I can hear you. Yes. Irene, you are frozen. Okay, I will proceed a little bit in the, for the purpose of saving time. And the first presentation is supposed to be my knee.
I can hear you. I can hear you. Hello?
Presentation.
Yes, yeah. So good evening, and everyone.
Okay. Can you give an
I'm very
introduction?
grateful for this great opportunity. And
my talk, and then we will proceed. I'm afraid there is a connection problem for Irene, and I wouldn't like to delay the session any further. So I would say that the first presentation was by me, and it is a short presentation regarding the aspects of transplantation surgery that are supposed to be to the knowledge and to within the competencies of the general surgeon. And I will explain to you why I see it this way and what are the challenges ahead of us. So I have control of the share screen, and we can start. So the title of my talk is General Surgery in Transplant Patients, What to Consider. And to put you in the picture, first of all, I don't know why it doesn't move on. Yeah. To put you into the picture, the incidence of end-stage kidney failure, chronic kidney disease and end-stage kidney failure over the last 10 years has increased dramatically, close to 31%, 32%, which is an absolute immense increase. And this, of course, translates then for the need for transplantation of these patients. If you see the national transplant data, most interestingly, you can see here that over the last years, with the implementation of all the recommendations of the Nation Task Force, we had a 24% decrease in the waiting list, 57% increase in the number of transplants, and 75% increase in the number of organ donors. So this is a very clear pattern that shows an increased transplant activity that creates a very big critical mass that we will discuss in a minute how is going to affect the general surgeon as well. Again, here are the national data when it comes to the trajectory of the number of transplants over the last couple of decades. And if you see the projection of NHS blood and transplant is that we will have an even bigger increase in the number of donors and transplants. And in the next 5 years, we expect 17% more donors, 23% more transplants, something like 500 to 600 kidneys, 250 livers, and 40 to 50 pancreases, hearts, and lungs. And when it comes to the follow-up of these people, which is even bigger, you can see here that is also going north, and we have approximately 37,000 patients under the post-transplant follow-up. So this is an absolutely massive number. The bottom, and also another thing that we need to keep in mind, which is massively important, is not only that the number of people that are being transplanted, who are being transplanted, is increasing by the day, and the trajectory goes north for the years ahead of us, but also the comorbidity of these people, the age and comorbidity are also increasing. When I was a registrar and was trained in organ donation, the average donor or transplant recipient looked something like this, like an Olympic gold medalist. When I was appointed as a consultant more than 2 decades ago, an average donor looked a little bit like this. And nowadays, the average donor and recipient looks a little bit more like that. So two big things, two massive things. First of all, very big numbers. Secondly, patients with significant comorbidity. And this leads to the point that we have now, and we will have even more in the future, a critical mass of these patients that cannot be handled anymore by the transplant centers alone. This old-fashioned mentality that we had in transplantation, that the transplant surgeon and the transplant team has complete and utter possession of these patients, will go out of their window simply because there are not enough resources within transplantation to deal with all the surgical problems of these patients. And this expertise has to come to a certain extent and up to a certain point within the skills of the general surgeon. When it comes to transplant patients, whenever we communicate with other university hospitals without transplant programs or DGHs, there is always terror, as if they are talking about transplant patients, as if they are talking about Martians. Transplant patients do not belong to another species. They have exactly the same surgical pathology like any other general surgical patient. However, there are certain things that one needs to take into account when we're dealing with them. First of all is the background of comorbidities. And you can see here some very big killers: anemia, diabetes, cardiovascular disease, and hypertension, which are prevalent within patients with kidney failure, and they become more prevalent as they progress through chronic kidney disease. The second thing is that transplant organs are more vulnerable to anything under the sun, to any kind of hypovolemia, to any fluctuations in the blood pressure, to the introduction of any new medications. So before you do or introduce anything to them, you always need to think about the tolerance of these organs in what you are introducing. A transplanted kidney is not like a native kidney, and a transplanted liver is not like a native liver. It functions the same, but it has certain sensitivities and tolerance, which is not the same like a non-transplanted one. And also you need to keep in mind the background of immunosuppression. With immunosuppression, we knock down the defense mechanisms of the recipient, and we do it nowadays much more elegantly and much more gently compared to what we used to do 20 or 25 years ago when the patients were put on industrial doses of immunosuppression. We do it in the acute post-transplant setting in the long run, but in both settings, we are knocking down the immune system. And this is something that you always need to keep in mind when you see a surgical problem in a transplant patient in the general surgical setting. The antibiotic prophylaxis they need, the whole handling of the prophylaxis or treatment of sepsis is much more challenging. I selected the two organs which are near and dear to my heart, kidney and pancreas transplantation, to comment on a few complications that can come and will come towards the activity of the general surgeons, and that can be dealt very efficiently, I believe, by the general surgeons. When it comes to complications following kidney transplantation, they can be categorized roughly as follows: urological complication in the context of leak or obstruction, peritransplant fluid complications, hematomas, abscesses and infections and lymphocytes, vascular complications in the arterial or the venous setting, calculus disease, neoplasms, and complications, and of course, post-transplant malignancies with a post-transplant dominant one. If you want to have a timeline, if you want usual infection, if there is trouble beyond 12 months, is an opportunistic infection, malignancy, or recurrence of the original disease that led to kidney failure. Beyond your common sense, clinical abilities and the choice, the most powerful weapon you have as a clinician dealing with surgical complications of kidney transplantation is ultrasound. Simple, non-painful, not expensive. It can be done on the bedside, but the information you can get on it is absolutely fantastic. When it comes to increasing the size of it, usually is an inflammatory or outflow process. If you see a decrease in the size of it, is usually an inflow process. If you see high resistance, is again inflammation or outflow process. If you see low resistance, is something that bypasses the arterial system. And if you see hydronephrosis, of course, something is blocking the outflow. It sounds very simplistic, but it can save your life in the middle of the night when you are dealing with a patient with a problem after kidney transplantation and you wonder what is the diagnosis of it. Doing an ultrasound like this, it can be the most informative element. And you can see here some characteristic pictures of hydronephrosis, and if this is being left untreated, it can finally kill the cortex, the functional part of the kidney. Lymphocytes or other big collections in the belly can press either of the vessels, and these are when they are lying medially, and this can be a killer for the kidney altogether, or it can press on top of it, as you can see on the right-hand side, and this can have functional consequences for the kidney. When it comes to the ultrasound, you need to remember these three pictures. This is the flow in a normal artery with pulsatile fashion, systole, diastole, with clear forward flow at the face of diastole. This is the picture of a normal renal vein with a continuous non-pulsatile flow, which is uninterrupted. And this is the picture of trouble. This is where you have reversed flow in diastole, which means that the blood goes into the kidney but doesn't progress because there is an intraparenchymal or outflow problem. This is an acute surgical issue that requires acute surgical intervention. So, simple picture you can keep in mind in the morning can guide your surgical practice for dealing with such a situation. Renal artery stenosis is a multifactorial complication that has to do sometimes with donor factors, atherosclerosis, fibromuscular disease. It has to do with recipient factors, such as, again, atherosclerosis or the presence of previous surgery. It can be related to surgical technique, and also infections like CMV and EBV can be related to the development of renal artery stenosis. To diagnose it, again, the lab results, the ultrasound most helpful, and in the vast majority of the cases now, if it is early spotted, the radiologist can solve it. Otherwise, it will require a surgical intervention. Other issues that you need to keep in mind in the context of dealing with those transplant patients in the context of renal surgery. First of all, is that the arteries of these patients are absolutely horrendous. Not only they have severe atheromatous disease in the vast majority of the cases, but they have the tendency to dissect and create all sorts of aneurysms and pseudoaneurysms. And which you need to have in mind when you plan anything to do surgically to them. Next thing to remember is that they can develop cancer much more frequently compared to patients who are not immunosuppressed. And the presence of PTLD can be very prominent, and you need to remember that it's not a surgical disease. It can be treated very easily sometimes, either by the reduction of immunosuppression or doing this in combination with very straightforward chemotherapy. The presence of massive polycystic kidneys. After the big killers, which is diabetes and hypertension, the presence of polycystic kidneys is a very common performer of kidney disease. And this comes, the presence of them, with three very specific complications: bleeding, infection, and the presence of malignancy. In a study that we did with Miss Bellini in removed kidneys, and we have the biggest series in the UK, in approximately 15% of them, there is underlying malignancy. So when you're dealing with these patients, always keep in mind that in the vast majority of the cases, they can get away without conservatively with bleeding or infection, but sometimes you have to do a massive operation to be able to remove those kidneys. And again, these patients being frail, being vasculopathed, and being immunosuppressed, when it comes to being suspicious about bowel perforation, if your index of suspicion for a general surgical patient is 1, for a patient with kidney failure in the context of immunosuppression should be 100. It is much more prominent, and if it happens and is not treated promptly, and this is where the general surgeon needs to intervene, not wait to transfer a patient to a transplant center someplace in the UK, it can be really lethal. The mortality of it can be much higher compared to the same pathology in a non-transplant patient. Pancreas transplantation. Pancreas is the troublemaker. Transplantability is fun, I would say. You do some fantastic elongation of the portal vein and the superior mesenteric artery and the splenic artery by using extension grafts that you get from the donor. You do some trimming of the duodenum and inverting the two ends of it to be able to prepare it for anastomosis in the bowel. We usually do a combined kidney, one in the right and one in the left iliac fossa. Very typical end-to-side anastomosis, checking the vessels bleeding, and then the pancreas, you can see here, beautifully reperfused like a normal pancreas with the duodenum bursting with exocrine secretions, which we then divert with a side-to-side. It looks beautiful, it prevents the recurrence of diabetes, and the world is a better place to live, if only. It comes with quite a lot of trouble. The biggest trouble in pancreas transplantation that you need to diagnose early when a patient like this comes your way, and you don't have to be a transplant surgeon for that, is thrombosis. And the pancreas gets thrombosed because it's an organ with very low flow, much lower compared to the kidney, and also is an organ which is very susceptible to the development of edema intraparenchymally, which is the biggest killer. And you can see here in this CT scan, the kidney on the left lighting up like a Christmas tree, and the pancreas on the right being cured, but only just, despite the fact that you have optimized your fluid balance and you have anticoagulate your patient and you have perfect surgical technique. The parenchyma simply is giving way in front of your eyes and is difficult to deal with. What leads into this situation is a variety of factors beyond the low flow. It is the presence of any hematomas during the retrieval of the pancreas that need to be avoided at any cost. The presence of peripancreatic and mostly intraparenchymal steatosis, which can lead to fat necrosis and pancreatitis. Not properly flushed small vessels within the pancreas. Tearing of the pancreatic capsule leads finally to this phenomenon of pancreas, and which is the first step to gradual thrombosis. And pancreatitis, it is pathology on its own right in the context of pancreatic transplantation. Again, something that you will need to deal as a general surgeon, and the treatment of the context of general surgery. Another big problem you can have is a leak from the duodenal anastomosis, especially when the duodenum has not been retrieved properly and the layers of it has been damaged, as in this occasion. And the last two things, my last two slides, one of the biggest problems that you can have in pancreatic transplantation that you will see commonly in general surgery is wound infection. If you think about it, you have experimental conditions for wound infection. You have a patient who is usually obese, diabetic, you do a bowel anastomosis, and you do this at the background of immunosuppression and close to the vessels. You are really in trouble. And that's why in many centers we strive the incidence of infection, of wound infection. Not in all of those situations particularly serious, but in some of them can be very serious and very chronic, and the cause of morbidity and on certain occasions mortality. And my last slide is a bit of a quiz. This is a patient who had a pancreas transplant alone for the treatment of his diabetes. The pancreas was removed. The infection developed at the pancreatic bed. And this was the picture in the CT angiogram and the conventional angiogram. And the question is, can somebody give us the diagnosis? Let's see the chat. Let's see the questions and answers, or the chat. Anybody with an answer? That's a mycotic aneurysm, okay? Which is one of the most difficult pathologies you can have to deal with in the context of transplant, vascular, or general surgery. And it is lethal, and it needs to be diagnosed as early as possible. And this is where the contribution of the general surgeon is absolutely crucial. So I'll be delighted to take any questions from the audience. I have my question screen here, and I'm instructed that the questions will come up here if you have any. Okay, nothing at the moment. which get us to the second part of the presentation of the evening tonight, which is the short posters, the short papers. We have two short papers for presentation and questions, and I will pass it on to Irene, who will chair the first one. Irene, I hope that you can see us and hear us now.
Thank you very much, Professor Papalos, for this very interesting lecture. Actually, I really enjoyed, despite the fact that after all this time, transplantation, I should. Can you hear me?
Now we can.
Can you hear
now
me?
We can. Yes, yes.
Can you hear me now?
Yes, Irene, we can.
Okay, I would like to introduce the first presenter, James Oliver, who will talk about outcomes of critical limb ischemia in a tertiary center. Are we meeting standards?
Thanks very much. Can you hear me okay?
Yes.
Great. So thanks for the opportunity. I'm going to talk about our project from Cheltenham General Hospital in the UK, looking at outcomes of critical limb ischemia in our patients and comparing them to standards. Next slide, please. So, in comparison, the Vascular Society of Great Britain and Ireland came out with a quality improvement framework in April 2019. The rationale for this was the high morbidity, high incidence, high mortality, and high costs associated with patients with critical limb ischemia, but also the inconsistent and variable practices which have been shown up in the GIRF data, the Getting It Right First Time data. So the aim of our project was to assess our current pathway for the patients, but also to compare it with the outcomes of the Vascular Society's quality improvement framework for critical limb ischemia. And the way we did this was a prospective data collection over 4 months, using both the physical medical notes and also the electronic records. And this is looking at all new patients admitted with critical limb ischemia over that time period. Next slide, please. So just breaking down the patients involved, those who met the inclusion and exclusion criteria were 61 patients. There's a predominance of male patients and older patients with an average age of 75. Our 30-day mortality rate was 5%, and the 30-day readmission rate in the trust was 10%, which the average of the UK and England anyway is 11%. The length of stay was very variable, and the average was 16, and a step up in care of 8% of people. And in terms of that, what I mean is people going from living independently to requiring care, or from that position to going to a nursing home. And of the Vascular Society's quality improvement framework targets, we met 50% of them already. Next slide, please. So in terms of this table here, you might be able to see that the time to consultant review, we met that target. However, the time to imaging and intervention, our time was too long. Next slide, please. Just to summarize really, so already we're meeting 50% of these brand new targets, which in the documentation was set out as challenging targets. But there are significant areas we can improve upon, which include pathway streamlining. So we work on a hub and spoke model, so getting those patients to the centre faster, getting through to imaging, specialist review and intervention in a quicker time period. We found key areas for documentation which can be improved, and another area with significant improvement can be our medical and geriatric input from our colleagues for our more frail and complex patients. And then we talked about the wound ischemia and foot infection score, the Wi-Fi scoring, which is something we want to implement, but of course you need specialist kit and equipment and knowledge for this. So that's something we're working on going forwards. So our aim will be to repeat this annually to make sure we're improving our outcomes for our patients and meeting the standards nationally. Thank you very much.
Thank you very much. Let's see if there is any question coming. Not at the moment. Okay, I've got a question for you. Very interesting presentation. What about the cost that you think this will be saving?
So we didn't do a cost analysis per se, but if we manage to get our patients from our more sort of distal hospitals to us faster, get them in we will definitely be saving bed days. And we know that a bed costs around £400 to £500 a day, so there'll definitely be cost improvements in this.
James, a question for me, if I may. You highlighted very nicely the way forward as to what else need to be improved. What do you foresee as the limiting factor, the bigger obstacle to be able to implementing these changes you are recommending there?
I think a key area which we can improve upon is our input from our colleagues in terms of medical and geriatric input for our more complex patients. And we've seen that the orthopedic teams and some of the general surgery teams have managed this very successfully. It's just providing that business case to do that. And then the second thing is the WIPO scoring is a good objective standard to meet from kind of audit purpose, but also from the care purpose. But that does require some more expensive kit and specialist knowledge. So those are two areas of key improvement that we can work upon going forward.
Thank you. We can now move on to the next presentation. And this is the impact of arteriovenous fistula versus arteriovenous graft on access performance in hemodialysis patient and systematic review and meta-analysis. And the presenter is Hannah Barton.
Hi, hopefully everyone can hear me okay. Thank you for the introduction and thanks so much for this opportunity to present. So if we just move on to the next slide, please. Oh, you'll have to click through. I'm sorry, I think this must be one with lots of action. So just keep clicking until you get the numbers at the bottom. Thank you. So access function is a really important outcome measure for hemodialysis patients. And me and my colleagues have looked into this a bit further and found that there's actually data sort of lacking on comparing these. Guidelines really say that fistulas are the first line really, but there's still a lot of controversy around this, whether we should be putting grafts in people with lots of comorbidities or elderly patients. So we aim to have a look at all the literature that's out there and actually compare these directly. So our methods for this were we looked at all comparative studies, so it was only comparative studies that we used. We used any patient over the age of 18 of any gender who was undergoing any form of fistula or any form of graft. And our outcome measures were looking at primary failure, primary patency at certain intervals, primary assisted patency at certain intervals, and then secondary patency, so effectively abandonment of that form of graft or fistula. And we also had a look with the Newcastle Ottawa scale at actually how biased or how good were these studies. If you just click again for me, please. So overall, we picked up on 18 observational studies with quite a large group, just over 118,000 patients included. Next slide, please. Just click through again, please. Sorry about all this animation. That's perfect. Oh, back one. So really sorry, a lot of data here. There's a lot of number crunching in this project and lots of sort of diagrams and forest plots I couldn't really include, but effectively just looking at the data here, fistulas have a higher rate of primary failure, but if you look through the primary patency, in the long term, fistulas come out pretty well. So although they have higher failure rates, they also have better long-term function compared to grafts we found. Next slide, please. And just click through. Sorry about these animations. So as I've said, we actually found that there was significantly higher primary patency in fistulas, but there are obviously downfalls to a sort of every literature review, and the evidence that was available to us, it doesn't look at everything. It doesn't address the sort of patient-centered outcomes, and going forward, that's the kind of thing we would encourage with further data around this area, is to look actually at what's important to patients and what's important to the surgeons as well. I'll just finish there. I think we're at time. Thank you.
Thank you, Hannah, very much for a very interesting presentation and for keeping the time. I would like to ask you one question. Did you differentiate in what you did between radiocephalic and brachiocephalic fistulae?
No, so actually that is another project we've got on the go. So in this particular review, we just chose any fistula versus any graft. So I agree that's quite broad, and that could be upper limb, lower limb. So yes, but we have got another one on the go that actually does compare those two, just it is actually a poster.
We'll be looking forward to this, but usually the radiocephalic ones are the ones that are adding failure, primary failure to the whole cohort of fistulae.
Yes, you're correct.
About infection, I couldn't see the data there. What was the comparison between the two when it comes to prevalence of infection in the perioperative and first year period?
That's a real shame because we don't have that data. We weren't particularly looking at reasons to why they've failed. We're just looking at sort of time scale. So I'm really sorry I can't give you that information.
No, absolutely. You can't finish anything in one study, but I think it's interesting to see when you compare them in the
reasons.
Analysis of your cohort.
Absolutely.
One of the big differences between the two. If there are no other questions to Hannah, thank you so very much. And we will proceed with the third part of our meeting now, which is the discussion of the posters. We have 4 posters to discuss, and Irene will chair the presentation of the first one.
Thank you very much. Delighted to introduce the first presenter, Amandeep Pahal. The treatment of mycotic aneurysm using endovascular aneurysm sealing. Just to go back to what Professor Papalos says.
Okay, I mean, Irene comes from Belfast, but we
cannot hear her. Can you hear her?
A little bit, but we have this mycotic aneurysm paper, and Amandeep will present it for us. Thank you.
Hello, my name is Amandeep Pahal and I'm a 5th year medical student at St George's University of London. So I'm here today to speak to you about the treatment of mycotic aneurysms using endovascular aneurysm sealing. So there is a gap in the literature because it's quite a novel treatment, and endovascular aneurysm sealing has shown promising results in non-mycotic aneurysms previously, demonstrated by Yusuf et al. However, there's no real pertaining evidence to its use in mycotic aneurysms. So the aims of my study were to explore the treatment of mycotic aneurysms and to assess the applicability of endovascular treatments as well. So I'll now talk you through the method of our study. So firstly, I completed a literature review, and following this, I analysed patient data on the electronic patient record system for 11 patients at St George's Hospital, and the data was reviewed retrospectively. The data collected included patient demographics, mortality rates, length of hospital stay, and also incidence of post-operative complications. So we found that the 30-day mortality post-intervention was 9.1%, and the 1-year mortality was 45.5%. So the mean length of hospital stay was around 16.2 days and the reintervention rate was 18.2%. So the complications encountered by all patients were also noted, and these included sac growth, endoleak, and also rupture. So me and my supervisor then calculated Kaplan-Meier survival estimates at yearly intervals without the various complications. So if we take a look at the freedom from mortality graph that's comparing the survival rates of aneurysm-related mortality versus all-cause mortality, the Kaplan-Meier survival estimates at median follow-up of 4 years for aneurysm-related mortality is 81.8%, but for all-cause mortality, it's 27.3%. So what this shows is that people are dying for other reasons other than aneurysms, and by operating on aneurysms, we're actually preventing these people from dying from aneurysm-related reasons. So in conclusion, the use of EVAS to treat mycotic aneurysms is associated with lower perioperative and post-operative complications. The reintervention rate was low, and due to the sample size being quite small and all the data being from the same institute, we may need to do much larger studies from different organisations to try and eliminate any bias as well. So thank you for listening.
Thank you so very much for a very interesting of work. Yeah, Irene, I'm sorry.
No, thank you. I was just going through, so congratulations. I was asking, is there any transplantations in your series?
I'm not sure if Amandeep could hear you. I think it was.
Yeah, sorry, I couldn't hear that properly.
If I can jump into this, as I said, I agree with Irene. It's a very interesting piece of work. It proves the point I made in my talk that a myocardial aneurysm is everybody's nightmare, no matter if you're a vascular surgeon, or a transplant surgeon, or a general surgeon. To come up, I want to ask you, Amandeep, about this 1 year mortality of 45.5%. Is this aneurysm related or overall mortality because of other pathology as well?
So the 1 year mortality for the 5, I think only 2 of the deaths only 1 death occurred within 30 days. So what we classed as an aneurysm related death was one that occurred within 30 days of the intervention. And only 1 of those deaths was within 30 days. So that was only 1 that was aneurysm related. So all the others were all cause mortality deaths. Yeah.
And if I may add another question, what kind of perioperative antibiotic prophylaxis you give in the context of the use of this device?
I'm not too sure about that, but I can have a look after this presentation.
It will be very interesting to see. Yeah. Very interesting to see. Thank you so very much, Amandeep. Great work, and we are looking forward to the next analysis of this important cohort. And we are moving to the next poster, please, which is perioperative prescribing in vascular patients, which is coming from the Musgrove Park Hospital in the Taunton and Somerset NHS Foundation Trust. And I think the presenter is India Cox.
Hi. Yeah.
Hi,
India.
India.
Can you hear me? Hi. So apologies, I'm in scrubs, I'm on call, and also my poster hasn't formatted it very well, but I'm presenting from Somerset on perioperative prescribing. So obviously many patients attending for vascular operations are also prescribed cardiovascularly active drugs, but our hospital has no perioperative guidelines for prescribing these. So we looked at 4 commonly prescribed drug classes: beta blockers, calcium channel blockers, ACE inhibitors and angiotensin receptor blockers, and statins. And we audited their prescribing against standards from a recent literature review from the Royal London Hospital, which, in the absence of any national guidance, we felt represented best available evidence. So I've included a summary of their recommendations, and the upshot is that the only drugs that are given throughout are dihydropyridines, such as amlodipine, and ACE inhibitors, which should be held on the day of surgery due to cardiac risk and intraoperative hypotension. So we aim to establish, does prescribing in our hospital match these recommendations, and is there a difference between elective and emergency admissions? Data collection was prospective over 4 months, and we included 84 patients having vascular operations. So we found there was around 80 to 90% compliance for most drugs most of the time. Compliance with the recommendations was lowest in the calcium channel blocker and ACE inhibitor groups on the day of surgery, with only 41% of CCBs and 54% of ACE inhibitors being prescribed appropriately on that day. So in the ACE inhibitor group, we also found there was a huge discrepancy between elective and emergency admissions. Although in some cases this was unavoidable, in many emergency cases there was actually time between admission and operation to hold the medications. Compliance was lower across all drugs on day 1 post-op compared to pre-operatively, and common appropriate reasons for this included hypotension, bradycardia or AKI. So in conclusion, most confusion seems to arise around prescribing on the day of surgery, particularly for ACE inhibitors, ARBs and CCBs. There was better compliance with the recommendations in patients who had attended a pre-op assessment clinic, which includes a medication review. And we think developing local guidelines to use on the wards would help to standardise practice. So this is how we are going to take this work forward. Thank you.
Thank you very much, India. First of all, there is no reason to apologize to surgeons for being in scrubs, actually. Perhaps we should apologize to you for being in suits and ties, actually. You are doing some hard work and we are not at the moment. But the question I have for you, you have here a very good deep dive into this practice. Based on your data, is this prescribing practice protocol-based or is pretty maverick? And based on individual preferences?
So at the moment, it's pretty much up to individual preferences. And we were finding that patients who'd been to the pre-op assessment clinic, if they'd seen a particular vascular specialist nurse who's clearly had some education at some point that says he should hold ACE inhibitors on the day, then they would have their medications held. But if they'd seen other people or they were clamped in by an F1, say, then they would just have all their medications continued. So we were concerned that there wasn't much standardization.
Thank you. And I don't see any other questions, so we can pass it to Irene for the last poster of this part of our evening.
Hello, so can you hear me now?
Yes, we can.
Okay, fantastic. Thank you very much. I would like to introduce our next presenter, about 150 early cannulation grafts, outcome analysis from a single center, Mukesh Garg from King's College Hospital, London.
Shall I start? Yeah.
Please.
Yes.
Yeah. Good evening, everyone. Many thanks for giving me the opportunity to present this one of our analysis. This is a poster on the topic 150 early cannulation graft outcome analysis from a single center. As we know that in patients with a multiple failed arteriovenous access, it becomes a challenge to provide any further new access. As per the Kidney Disease Outcome Quality Initiative and European Society of Vascular Surgery 2018 guidelines, there is a class 1 recommendation to use early cannulation graft or multi-layered self-sealing graft as a catheter sparing strategy in patients requiring urgent hemodialysis. AccuSeal is one of the novel graft, which is a tri-layered self-sealing graft, which has anti-thrombotic properties as well. Our aim of the study was to assess the outcome of early cannulation graft, and in our center, we are using AccuSeal as a early cannulation graft in all our patients. This is a retrospective, non-randomized, single-center observational study, and the study period ranged from March 2016 to August 2019. Data was collected from the electronic patient record of the hospital. Data in the form of the access summary, days to cannulation, reinterventions were collected and entered into the Microsoft Excel. Primary outcome was assessed in terms of primary and cumulative patency, and subgroup analysis was formed in terms of the race distribution. That is in our southeastern London population, there's a lot of Afro-Caribbean population as well. So we compared Afro-Caribbean versus white population, loop versus straight graft, and brachioaxillary versus brachiocephalic interposition graft. Statistical analysis was performed using Kaplan-Meier survival curve. In our study, 152 grafts were formed in 122 patients with mean initial multiple failed access of 2. Male to female ratio was almost 1:1. It was actually 1.1. Age range was from 30 to 87 years. Mean BMI was 31. The median number of days to cannulation was 4 days. Cumulative graft patency at 3 months was just over 70%, and at over 12 months, it was just less than 35%. 23% of patients died during the study period. 11 were transplanted. 11 had their graft explanted following the graft infection. 10 grafts were never used. There was a very high reintervention rate with an average reintervention rate of 2.54. This was in the form of the graftoplasty, outflow venoplasty, stenting, graft thrombectomy. Graft thrombectomy was either surgical thrombectomy or IR thrombectomy. We also assessed the subgroup analysis, and there was no statistical significant difference was found on that subgroup analysis. In the end, the early cannulation graft is a safe and practical alternative in patients with multiple failed access. We don't know the cause for the multiple failed access because these patients already have some kind of prothrombotic, can have some kind of prothrombotic conditions. That's why patency rates are also coming out to be towards the lower side. Upper limb is preferred over to the lower limb because upper limb has lesser chances of infection. And this is although this is one of the solution for multiple failed access, but it has a high reintervention rate. So it's a which requires frequent interventions. Many thanks. Thank you.
Thank you very much for your presentation. I've got a question. So the grafts that were never used, what did you do with those grafts? And eventually, how did this patient dialyze then?
Actually, in these patients, initially the graft were placed when they were in the CKD stage 3. They never reached to the stage where they need to be dialyzed, but they were getting their AV access ready for the dialysis. So eventually, these patients managed to get their grafts, but they were never dialyzed. That's why these grafts were never used.
I see. So you left anyway the grafts in there even if the patient didn't need dialysis?
Yes.
Okay. And another question is about, so you are very aggressive in preparing the access for the patient, but this sort of preemptive access, you decided to place a graft because the patient didn't have suitable veins?
Initially, patients had multiple failed access. We tried autogenous access first. That was the first choice. If the autogenous access fails, then we tried to go for a AV graft. Actually, this is not the first thing which we were going for, the AV graft. So this is after multiple failed access. And as I told you that there's an average number of the graft before the average number of autogenous access is 2. This is the mean, which is the 2 AV access procedures were done before any kind of AV graft in all the patients.
Okay.
Mukesh, your good work is generating interest, and to have a question from Samuel De Bono about your surveillance program related to early cannulation grafts.
There is no specific surveillance program in patients with initially with the AV graft, but when the AV grafts were checked by our regular dialysis team, if they find any problem with the pressures in the dialysis machine, then they refer to us, and then we will investigate it, and we will go ahead with the surveillance scan. There's no specific surveillance program in terms of 1 month, 3 month, or 6 months, 12 months, as in the FEMPO bypasses. There is no specific surveillance program.
And if I may, one question from me, because we have seen the use of these grafts in our program as well. The dialysis nurses, I can tell you, they absolutely love them. So in your view, what is the most important limiting factor?
I'm not able to hear, actually.
Yeah.
Can you repeat again?
Can you hear me now?
Yes, I can.
What I was saying is that these grafts are very popular, especially the dialysis nurses absolutely love them. So I would like to ask you what you believe is the most important limiting factor in using them?
The main limiting factor is the needling of the grafts. In the graft, we never want any kind of buttonholing of the graft, because buttonholing will degenerate the graft, and this will lead to infection, false aneurysm, and bleeding. All kinds of complication can happen. So we always advise them that always use the raw platter pattern of needling for the graft. That is one of the things which is there. And apart from that, sometimes even if the higher pressure is there, then we don't get reported with by the dialysis team. That leads to the failure in the grafts because of the central venous occlusion.
Very good piece of work, Mukesh. Thank you so very much. Very interesting. And we are moving now to the last poster presentation for the evening, which is about correcting von Willebrand factor deficiency using coagulation factor concentrates for an elective case of live donor kidney transplant, donor overcoming barriers to kidney transplantation. And this is coming from Sheffield, from the unit in Sheffield. And I believe that Mr. Murray is presented. Mr. Yazin Murray.
Yes, correct. Thank you. Thank you, everyone. Hi, everyone. I'm Yazin Murray, a renal transplant surgeon from Sheffield, and I would like to present to you a kidney donor who was found to have von Willebrand disease. First of all, I have no financial conflicts of interest to disclose. As you know, von Willebrand disease is a hematological condition that can be challenging to deal with during any operative intervention. And on the other hand, kidney donors shortage is still the most important issue facing kidney transplantation. So we're reporting a successful case of a live kidney donation with von Willebrand factor deficiency. Excuse me. So this case had of course no operative complications. That's why we are presenting it. Our case is a 43-year-old female patient who wanted to donate a kidney to her relative with end-stage renal disease. The donor is fit and well, but during the course of routine investigations, we found that the patient had abnormal levels of activated partial thromboplastin APTT ratio of 0.37 international units per mil, and just to tell you that the normal range is between 0.48 to 1.73, as well as factor 8 level of 0.58 international unit. So she was reviewed by we referred her to the hematologist, and she was reviewed by the hematologist, who recommended treatment to increase the von Willebrand factor activity to at least more than 0.5 international unit per mil. And the options we had is either with D-amino, D-arginine, vasopressin, DDAVP, or coagulation factor concentrate, CFC. So we had as usual, we had a following, we had a multidisciplinary team discussion, and it was decided that the coagulation factor concentrate was deemed to be the best option in her case. So the thorough discussion was made with the donor, and with regards to the small risk of transmission of blood-borne viruses, despite the course of immunization that was offered to her earlier. The donor received Vancento, which is a combination of von Willebrand factor and factor 8, and had an uneventful hand-assisted laparoscopic left donor nephrectomy. She was discharged home on day 3, then followed up in the clinic with no complications to report. And she continues to be seen in the routine yearly follow-up as per our unit protocol. The recipient, on the other hand, she had an excellent graft function. So to sum up, the donors with von Willebrand disease should be considered for live kidney donation following perioperative correction of von Willebrand factor. But of course, the most important thing is the discussion in the MDT as to which, the donor should be involved, of course, in the decision-making process as to which route of treatment to choose from, including the risk of transmission of blood-borne viruses. Thank you for listening.
Thank you so very much. And as a transplant surgeon, I applaud what you did, which is fantastic. And what's important is not only what you did, but how you did it. The pathway that you followed with identifying the problem, preparing the solutions, putting the patient into the picture, discussing the potential problems, and then proceeding. It's absolutely fantastic. And it's great to see that we keep on pushing the frontiers of living donor kidney transplantation. My question to you is, did you change anything in your intraoperative?
Sorry, just a question. Did I change anything in the?
Your intraoperative strategy compared for this specific case?
I think I'm just going to reiterate. It's just going to just, if you don't mind, if you just repeat the question, because the sound wasn't very clear. Did you say did we change anything intraoperatively?
In your intraoperative strategy, in your intraoperative practice?
No, it was like the intraoperatively, there's no changes, exactly the same standard procedure. It was completely like, it was uneventful at all, but there was no change at all.
And do you know how many cases like this have been done in the UK or beyond?
The only one I could see, there was a publication from Belfast that was a different coagulation. That was a hemophilia A or B, I can't remember. I think it was hemophilia A. It was publication from Belfast, and that one, I mean, for that patient, there was a hereditary condition. There was some mutation for that donor, as far as I can remember. So apart from these two, apart from our case and their case, I couldn't see any other cases.
And were there any difficulties in getting permission from the Human Tissue Authority to perform this transplant?
In what terms? In
the terms of the independent assessor review and finally getting permission to go.
No, there was no difficulties at all, especially the fact that we have discussed the consequences and the possibility of lack of, I mean, the possible complications with the patient. To be honest, this patient was assessed by one member of the team, and to start with, we thought we should not go ahead with it, but then it was, like, of course, brought up in the multidisciplinary team meeting, and we thought we should involve the hematologist. And then, I mean, as you saw from the presentation, we went ahead with the donation.
And can I just ask a question? So, do you have normally thresholds? And in this case, would you? Can you hear me?
Yes, I can hear you now.
Oh, okay, thank you. So, very interesting case. I was wondering whether you normally have some thresholds, like let's say age, BMI. So, if this would have not been the case for a 43 years old female, but let's say would be a 74 male with a BMI of 40, would you go ahead as well?
I think, and I know that I might get some criticism from the panel about the BMI. In our center, we probably the 40 BMI, we think twice before we go ahead with the donation, number one. Number two is just to answer your question specifically. It's what we did, and after discussion with the hematologist, is we corrected the coagulation deficiency, and we dealt with it as if it's the same. So if it was a 72, let's say BMI 35, I will put it this way, we would go ahead, of course, after discussion with the patient.
Thank you.
Thank you. Yasin, thank you so very much.
Thank you so much. Can I just mention one point is the decision to choose between the CFC and DDAVP was based mainly, of course, with the discussion with the hematologist, was based mainly, the reason why we preferred it to start with is because because of the side effect of the DDAVP. So as you know, it's an antidiuretic hormone, and we normally hydrate the patient. We would like to keep the donors, as you know, postoperatively or perioperatively hydrated, and so we didn't want them to go into fluid overload. So after giving the DDAVP, but of course the side effect or the possible side effect of the coagulation factor concentrate is the possibility of the blood-brain viruses, which was discussed with the patient, and as we mentioned, we did give the she did receive the immunization before that.
Yasin, thank you so very much. This is a very important piece of work. Warm congratulations.
Thank you so much.
And this brings us, I think, to the last part of, if we can have the next slide, is to remind you kindly that there are e-posters on this web link that you're more than welcome to visit and come up with tomorrow at 6:30 again. We have the big session about the Moynihan Prize and the other prizes of the HGBI Congress, which is now into virtual sessions. It will start 6:30 tomorrow evening with some fantastic presentations and a very big competition for the Grand Prix of the HGBI. So I hope that you will be able to join us. I would like to express my grateful thanks to my co-host, Irene Bellini, for putting this together. Sincere apologies for the small technical hiccups. Thank you for being with us and have a very nice evening. Thank you.
Thank you very much. Thank you.
Thank you.
Thanks so much.
Thank you.
Thank you.